Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, my incredible and knowledgeable nurse practitioner, Rosalind Arp, and I share our combined 30 years experience to guide both men and women as they age. Listen as we dive into a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. These real-life insights are always rooted in solid scientific knowledge. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Welcome, everybody, to our Burning Questions podcast. Today's episode is all about the things that can make the vagina and vulva feel irritated, itchy, red, raw, swollen. We've heard all of those terms when people come in to say that they have a concern.
Most women automatically jump to a yeast infection and they treat with over-the-counter medications. While yeast infection is common, it is by no means the only reason for women to have itching or irritation.
So the first question we ask patients when they come in is, where does it itch? Are we talking about itching on the outside of the vagina, which is called the vulva? Is it itching up inside the vagina, or both? So let's talk about what the anatomy is in those two areas. The outside of the vagina is called the vulva. This has many different structures in it. The labia majora are the lips outside the vagina that have hair on them. And the labia minora are the lips outside the vagina that don't have hair. They just look like skin. The vestibule is an area that is located between the urethra and the vaginal opening. And the word vestibule actually means door. It's like the door to the vagina. This area holds the urethra, the bladder opening, some gland openings, and lots of nerve endings. So if it gets irritated, it's a common area to itch. And then we also have the clitoris. Now, the gland, the little bump of the clitoris, what you see is just the head of the clitoris. It has a piece of tissue over top of it called the clitoral hood. And there are actually two clitoral arms that are buried deep underneath the lips of the vagina. So in order to really get a good look at the clitoris, you need to push the hood back to see the entire glands, but we can't see the arms that go behind the labia.
And the vagina is the tube inside the body that can only be really visualized using a speculum. You can feel inside the vagina and see what discharge can come out of it, but usually you'll need a doctor or a provider to look inside to see what's going on.
Many women have never actually really taken a good look at their vulva. And this is something we do pretty commonly in our office. I will take out a mirror and use a little Q-tip as a pointer and evaluate each structure for the patient while she's looking in the mirror. And I've had patients in their 40s, 50s, or beyond be so excited that I've given them this little anatomy lesson. Many of them will say, I've never known this stuff. No one has ever pointed out to me that this is where all the parts of the vulva are. At home, if you want to look on your own, you can use a tilt mirror, and that makes it pretty easy to see the vulva. Some patients will ask if they should take a selfie with their camera in order to get a better look at the vulva. And actually, it's pretty hard to take your own vulvar selfie. It is a little easier if someone takes it for you. But where a picture may be most helpful is if you feel like you have a little bump or a lesion. If you're able to get a good photo of it, you can enlarge it and look at the edges and the characteristics of it a little bit closer than maybe you can just with your eyes in a mirror. As for your internal vagina, as Rosalind told us, it's really hard to examine that on your own. That part is probably best left to your physician.
And don't look for the first time when there are symptoms. Everything looks red and you have no comparison to what really does look normal. I had a patient once say that she had a bump on her vagina with itching, and upon inspection, it was actually her clitoris.
And that goes back to knowing where your normal anatomy is, so you know what is normal and when something goes awry.
The other question I usually ask my patients is, how long have they been itching? How severe the itching is? And are there any other associated symptoms with it, like burning, abnormal discharge? What does the discharge look like? And when did it start? Sometimes when patients are saying, oh, I itched one time after I worked out and I'm coming today to see if that's a yeast infection, I usually tell them, I'm like, unless you're like severely itching and cannot stop yourself from scratching, typically itching can just be an irritation on your skin at that moment.
And we also take into account the patient's age and menopausal status because that helps us look at what the diagnosis might be. Some conditions are more common in younger women who are still having their periods, whereas other conditions might be more common after menopause.
And the most common reason for itching is yeast infections. A vaginal yeast infection usually shows up as cottage cheese discharge with itching and burning. Your provider can do a vaginal swab to test for a yeast infection. You may try to treat with over-the-counter medication like Monistat or Meconazole. They come in 1 and 3 day formulation that usually treats up to 7 days.
And there's really no difference because the 1-day ovule is formulated, even though you place it for only once, it's formulated to cling to the vaginal walls and treat for up to 7 days. Just like the 3-day formulation, you place it 3 times, but it's formulated to cling and stay in there for up to 7 days. Any med that ends in azole can treat a yeast infection, and it does so by suppressing yeast growth, like slowing down the growth of the yeast. It doesn't actually kill the yeast. But not all yeast infections create that typical cottage cheese discharge. If you have a yeast infection in the vulva, the area outside the vagina, you're not going to have a lot of discharge symptoms, but you may have a lot of itching symptoms. In this case, even if we do a vaginal swab, it may come back negative for yeast. So you can be erroneously told, oh, you don't have a yeast infection, when in fact, the yeast is located in the vulva. A vulvar yeast infection is very similar to a baby's diaper rash. Sometimes the lips of the vagina can be red and irritated. If you scratch them too much, they can get thickened as well. Sometimes you'll even see tiny little paper cut looking areas. Those are called fissures or peeling of the skin. That can all be associated with a vulvar yeast infection. The intravaginal Monistat or over-the-counter products generally don't treat this very well. We usually have to use something like an oral fluconazole. The trade name for that is diflucan, and that tends to penetrate the vulva a little bit better.
Do we always need to treat vaginal yeast infection? Typically, for a healthy woman, maybe not, but our own immune system will likely wipe it out. But for some patients, treatments will bring faster relief by slowing growth of the yeast so the immune system can catch up. What I also tell my patients, if they see a cottage cheese discharge, sometimes that might just be the thicker part of their discharge cycle right before their period, and it may not be a yeast infection if there's no associated symptoms like itching or burning.
Sometimes, though, patients truly do have yeast infections, and they can be recurrent, meaning you've treated, you felt better for a short time, but then the symptoms return. This is usually not related to a treatment failure. It doesn't mean the medication you took didn't work. It really depends on what strains of yeast you have in the vagina, because certain strains are more difficult to treat or take longer amounts of treatment to get rid of them. It may also be related to medical conditions that you have. So patients with diabetes or who are taking anything that might suppress their immune system are more likely to have recurrent yeast infections. And we have to think about the environment. Yeast like to live in moist, dark places. Well, that definitely sounds like the vagina, a moist, dark place. So anything we can do to reduce that, like keeping dry in the vaginal area, removing our wet and sweaty clothes right away. We don't like people walking around after they've worked out and been sweating, or if they've been swimming. We want to try to reduce the environment that yeast normally live in. And some patients ask me if they should decrease sugar in their diet. The data on that is mixed. Yeast do flourish by processing sugar. That's how they grow and multiply. So some patients have had success by either cutting out sugar from their diet or even doing a low yeast diet, but we can't say that it's consistently helpful.
And some patients tend to get a yeast infection after taking a high dose of antibiotics, not because it increases yeast, but just kills off the good bacteria that's in the vagina. So it allows yeast to grow after. An even unusual risk of increasing yeast infection, like I had a patient specifically who had an IUD who had recurrent yeast infections that we kept trying to treat for over a year. And finally, she just really got tired of it. And she thinks it was the IUD strings that was irritating. And once we removed it, the yeast infection went away.
That is very uncommon. In general, women with IUDs do not have an increased risk of yeast infections, but it's something that you need to evaluate for. So all of the medicines that we've talked about, the ones that end in azole to treat yeast infections, work the same way. They work by suppressing the growth of yeast in the vagina. There's actually the first new oral medication that has been on the market in the last 20 years to treat yeast infections. It has a really difficult to pronounce name. It's called a Brexafungert. It is not in that azole category. So this medication actually kills yeast rather than just slowing its growth. So sometimes if patients have had treatment failures using the typical azole medications, or if they have a yeast strain that is more difficult to treat, we may try this new medication. So it's nice to have something new on the market for yeast infections.
There is a new azole medication currently waiting for approval that has a half-life of a year. We're not really sure about the mechanism of action of this medication. We're still waiting for it to be released and for us to evaluate the data, but we know for sure that it's not going to be approved for pregnant women. So more than likely, this medication will be for patients who are done with childbearing.
And sometimes my female patients will ask me, can their male partners get yeast, or can they get a yeast infection from them? And the answer in theory is yes, men can get yeast infections. It's just much less common. As we mentioned, yeast like to grow in moist, dark places, and that doesn't really sound like the penis. That's much more common in the vagina. But yeast infections might be more common in uncircumcised men because that area under the foreskin of the penis is a moist, dark place. We would only typically treat a man with a yeast infection if they're symptomatic, if they have redness, itching, if they pull back the foreskin of their penis and they see a little bit of cottage cheese discharge. That's pretty classic for a penile yeast infection in a man, and that can be treated with oral azoles similar to a female yeast infection. And just like women can have vaginal yeast infections and vulvar yeast infections, men can get yeast at the tip of their penis, or they can get what they call jock itch, which is the equivalent of vulvar yeast infection.
So most of our patients come in when they're having itching, thinking it is a yeast infection, but sometimes there are other skin conditions that can cause itching and burning. The most common one I see, especially, is with my perimenopausal or menopausal women who come in complaining of itching with no discharge, and that's typically caused by atrophy or vulvovaginal atrophy. This can get worse during menopause, especially when we're not using vaginal estrogen cream. The skin gets really thin and there's less lubrication, which can cause the tissues to be itchier.
If you regularly listen to our podcast, you will know that we talk about atrophy quite a bit and all the different treatment options for it, but they mainly center around using vaginal estrogen therapy. It is the quickest and easiest way to restore blood flow to the vagina, to thicken up those tissues that tend to thin with menopause and perimenopause, and to reduce the itching and irritation that it causes. It also helps to improve pain during intercourse and dryness during intercourse. So vaginal estrogen is always at the foundation of many of our treatments in the absence of any other signs of infection.
There are some less common skin conditions that can happen on the vulva that are often misdiagnosed as yeast infections. One of them is lichen sclerosis. Lichen means thickening and sclerosis means scarring.
So lichens are actually a white algae that live symbiotically on certain trees. When lichenoid disorders of the vulva were first discovered, it had this whitish appearance to the vulva that reminded them of the lichen that they found on trees. And that's actually how it was originally named. The condition is likely autoimmune, which means that our body attacks the vulvar cells when it shouldn't. There are lots of other autoimmune conditions in the body. You can have autoimmune thyroiditis. You can have autoimmune conditions in the liver or kidney. This just happens to be an autoimmune condition of the skin of the vulvar region.
The typical symptoms of lichen sclerosis is itching and thinning of the skin or of the vulvar area, which looks like crinkled paper, or as we used to say, cigarette paper. And it can happen at any age. Typically, when that thinning of the skin happens, it can split open and cause the tissue to adhere to each other, which causes narrowing of the introitus, which is the opening to the vagina. It can also cover the clitoris and the urethra, and sometimes even loss of the labia minora, which is the smaller lips of the vagina.
So a skilled clinician can diagnose lichen sclerosis just with a good vaginal exam. But if we're not certain, we may need to take a biopsy to confirm it. What I found, though, is you really need to have a skilled pathologist to interpret your vulvar biopsy. I've taken so many vulvar biopsies to help confirm my diagnosis of lichen sclerosis, and many times it just comes back as inflammation. That's a general term. It's not very helpful. But if the pathologist knows what they're looking for, they can look for those lichenoid changes and help to confirm my diagnosis. One of the other reasons we might biopsy is that there is a small association with lichen sclerosis progressing to vulvar cancer. It's only about 4%, but it's one of the reasons why we have to treat and follow lichen sclerosis over time to make sure none of the areas have turned into a cancerous area. And certainly a pathologist should be able to pick up a vulvar cancer on a biopsy if we send it to them.
This is also actually the time I teach the patient to look at their vulvar area on a regular basis. And if they see any changes or any lesions that are not going away, that they need to come in sooner for their follow-up rather than waiting their 6 months or 1 year follow-up with us.
So when we treat lichen sclerosis, our main goal is first to improve the patient's symptoms. We want to stop the itching, stop the irritation, and also prevent scarring. And the way to do that is typically with a high potency steroid ointment. Now, steroids have a mixed history in the vulvar area. When we use them high potency for short term, they really can improve the itching and inflammation associated with lichen sclerosis. However, if you use high potency steroids on the vulva long term, you can actually have the opposite effect. You can have steroid induced thinning of the tissue, and then you have to discontinue it. So we usually use these high potency steroids short term in short little bursts in order to decrease the inflammation and itching. We need to make sure that the steroid ointment is applied correctly. So the skin, which has now usually been irritated and thickened from all the itching, sometimes it helps if you take a warm sitz bath or a warm bath to soften up the tissue and then apply your steroid cream so it will penetrate better. And you want to only use a pea-sized amount and massage it in really well. You don't want it to just sit on the surface of the tissue. We need it to get to those deeper layers. So apply a thin amount, massage it in for a good 60 seconds or more. And usually we'll recommend that you treat twice a day for anywhere from 2 to 4 weeks until the symptoms have improved.
I usually bring those patients back as well to make sure that the lesions that they originally presented with has completely cleared. So if you're the patient, make sure you are being followed closely when you have any new lesions that you're currently treating with the steroid.
After steroid treatment, some patients improve somewhat, but not enough. And we may say, great, we don't have any further scarring, but she's still having irritation or burning or pain. And that's when we may have to move on to the next step. One of the best procedures for treating lichen sclerosis is actually microneedling of the vulva. And that may sound a little bit scary, but microneedling and radiofrequency to these scarred areas is a great way to break up the scarred tissue. Microneedling involves using a little handpiece that has tiny coated microneedles that go into the tissue and break up the scarring. But at the tip of the needle, radiofrequency energy is applied. That's going to help to stimulate new collagen and elastin growth. So we want to break up the old scarred tissue that's there and help to replace it with new, healthy, natural tissue. That new tissue should be flexible. It shouldn't be splitting and breaking like you described before and sticking together, and it reduces a lot of the symptoms for the patient.
Do you recommend that for patients who have a current flare or for patients who have scarring only?
I think for a current flare, I'd start them on their steroid cream and calm that flare down. Because when they're having an immediate itching flare of lichen sclerosis, that's high inflammation. So a high potency steroid shuts that down. The microneedling treatment is best when I start to see scarring happening, or unfortunately for some patients, by the time they present to us, there's already significant scarring. We've seen cases where the clitoris is covered, the urethra is partly covered, and the opening to the vagina is really small. They're unable to be sexually active. So using microneedling in those patients is really helpful for restoring normal vulvar anatomy.
I know you have to do surgery for some of the patients who've had severe lichen sclerosis. Can you tell us more about that, Dr. Jackson?
It's very uncommon, but in rare cases, yes, I have done surgery to actually separate the labia. Usually I have to do surgery if the urethra, which is the opening to the bladder, gets blocked. Because when that happens, the urine doesn't come out in a straight stream anymore. Sometimes the urine even kind of shoots back into the vagina. It doesn't empty well. Patients get increased infections. So for those patients, we really need to get in there and remove the scarring, restore the opening to the bladder, and if we can, try to open up the vagina a little bit. But remember, because this is a scarring condition, it's just tightening of the tissue. If I just go cutting that scarring out without treating it in another way, it may recur. So that's why it's always combination treatment between steroid ointments and microneedling and surgery if needed.
And to maintain any flare, what we usually recommend for patients is to use their steroid cream 2 times per week to prevent any more flares.
And that maintenance treatment also helps to reduce the risk of cancer progression from lichen sclerosis. So we want to make sure that patients with lichen sclerosis know it's not just a one-time treatment. They want to maintain ongoing treatment and follow-ups with their physician to prevent the risk of cancer.
Speaking of vulvar cancer, another condition that can cause itching is vulvar cancer. I had a patient actually who went to her primary care, or I think her gynecologist, multiple times and was treated with diflucan without having any vulvar exam. So by the time I did her exam, that's when I noticed a non-healing sore on her vulvar area. And after I biopsied, came back as vulvar cancer. So it is very important for patients to get a vaginal exam or a vulvar exam if they have persistent itching, even with medication.
I totally agree. Prescribing just based on symptoms has repeatedly been shown to be non-effective. They've actually studied patients who've had a prior yeast infection. And when they get a new infection, patients are actually very poor at diagnosing themselves. Sometimes that new infection is a repeat yeast, but sometimes it's bacterial. Sometimes it's one of these skin conditions. So unfortunately, this is not an area where self-diagnosis is going to be helpful.
One of the complaints we get from our office is that we require patients to come in for a lot of these medications, but this is the reason why I've seen so many things that are not yeast, and they're calling in and requesting for a yeast medication. We've always required them to come in as much as possible to see, especially if it's persistent. We just don't keep sending them azole medication over and over because we want to make sure that there is nothing else happening. It's important for us to catch that early on.
So one of the final conditions we wanted to discuss is another lichenoid condition, but this one's called lichen planus. So lichen we know means thickening, but planus is actually a word for flat. Lichen planus is an inflammatory condition of the skin, but it doesn't just occur between the legs. It can occur anywhere on the skin, inside the mouth, in the hair, in the genitals, and we're not really sure of the cause of it. It's possibly autoimmune, where your body attacks its own cells. There's some data to suggest it might be a reaction to hepatitis C infections. It might be a reaction to the metal fillings in your teeth, or even reaction to certain medications that you may have taken. So the cause of this one is a little bit up in the air. It occurs in both men and women. And if women come to us with vaginal symptoms, we kind of have to look at the rest of their body to see if they have any of the other additional symptoms.
I actually had a patient who had a history of lichen planus on her legs and her mouth, and she was being treated with that, but she came in with complaint of vaginal bleeding. She's had a hysterectomy, but we just wanted to see where is this bleeding coming from, and she was unable to give a better description. And when I checked, I saw the red plaques and explained what lichen planus was, and her daughter actually said, "Oh, we just treated that last year on her legs," and showed me a scar. So that was a quite interesting case.
Right. And that's why even though we're looking between the legs for 90% of our job, when we find plaques of lichen planus, we have to look elsewhere. So on the vulva, these plaques actually look like bright red or even violet purpley patches that are very itchy for the patient. On the skin, they can also look like those flat purple patches. If lichen planus occurs on areas like the ankles or the elbows, they can actually become thickened plaques. So it can be a purple plaque with some whitish thickening on top of it. Your nails can have changes. They can look thin or have ridges or splits. Inside the mouth, inside the cheek, we can see a lacy white appearance. Again, that lacy white is the lichen look inside there. And on the scalp, you can get little red patches around your hair. Now, not all of these patches are necessarily symptomatic. For many patients with lichen planus, they may have it and not even know it. But if they are symptomatic, we want to go ahead and treat them.
Lichen planus also may resolve on its own in 2 years, but there's still a small risk of cancer progression if it doesn't resolve. But there is no association with scarring, so that's why our treatment is not as aggressive.
So if you are symptomatic from lichen planus, we start with just local care, keeping the area clean and dry, We can use some steroid ointments if they are inflamed and itchy. If itching is a problem, especially at night, sometimes we'll use some antihistamines. They work really well to stop that scratching that seems to intensify as soon as we go to bed. And for plaques and lesions that are resistant to those types of therapies, there are even some advanced treatments like with UV light or some additional medications to really decrease the plaques of lichen planus.
Though these are some of the more common reasons for vulvar itching, there are other conditions that can cause these symptoms, which can include contact dermatitis, psoriasis, hidradenitis suppurativa, eczema, Paget's disease, and many more. But what we really want to focus on today is how to take care of our vulva.
Luckily, the vulva doesn't need a lot of aggressive cleaning. You may have heard that the vagina is self-cleaning. Remember, the vagina is the inside tube, and that's really true. The vulva is the outer skin, and sometimes if we over-clean the inside and the outside of the vagina, we remove a lot of the healthy bacteria that is there to keep us safe in the first place. So our number one rule in cleaning the vagina is definitely no regular douching. Douching really just washes out the healthy bacteria rather than replacing it with anything good.
When using soaps or body washes, what we recommend for patients is to use a mild soap on the outside of the vulva, but not inside the vagina. Just like we wash our face with facial cleansers, or we don't wash our mouth with our cleansers. So the vagina, we just leave alone, and then the outside we can clean with a mild detergent.
I'm fine if you're washing the external vulva with a gentle cleanser. I tell patients Dove. Dove is the easiest thing because you can use it neck to feet, vulva, nothing in the vagina. And I also recommend that patients don't overly scrub the vulva themselves with either a washcloth or a loofah pad. I really just have people suds their hands, wash gently around the outside, and rinse really well. You don't need to do much more than that. Fragrances in general are irritating to the vulva. And I think somehow in the United States, we've perpetuated this idea that the vulva should smell like a garden or like perfume. And that's not true. We don't want to be putting those scents on the vulva. For many women, they're really irritating. A normal, healthy vagina and vulva generally has no smell, or it may just have the smell of your natural body. It shouldn't have a flowery fragrance.
Can you exfoliate after shaving?
I generally don't recommend that people exfoliate the vulva. It depends on the product you use. Exfoliants are little chips of things like ground up nuts or something that rub off the top layers of the skin. And depending if you're using an inferior product, it can really actually irritate the skin. If you're using a high quality product, it might be a little bit better. There are certain medical grade exfoliants that have tiny little balls that are all the same size, that are non-irritating, that may work better. But in general, I feel like patients should not need to exfoliate around the vulvar area. Now, I think what you might be asking about is in the bikini area where the leg meets the torso. In that area, that skin is a little bit different, and a little bit of gentle exfoliation there might be helpful if you are prone to ingrown hairs. But as for the lips of the vagina, I would not exfoliate in that area.
And the mons pubis as well.
And the mons, right, is also different. If women are shaving their mons, then that's an area where ingrown hairs can often happen, and you can gently exfoliate there.
Some of the things you can do at home to help alleviate the itching symptoms is using an ice pack, better than scratching. One of the recommendations I had is actually freezing a pad. And I learned that actually after having babies, freezing a wet pad in the freezer and then putting it in your underwear, which can help alleviate some of those symptoms. You can also take a Zyrtec or an antihistamine to help prevent itching, especially at nighttime. And then there's also many things in the market now that's specified for feminine wipes as with different fragrances. But what we really recommend is just using water wipes, which is purified water on textured wipe, or using a bidet or a peri bottle that has water in it to just feel like more moisturized in that area. And lastly, I do recommend A&D ointment, which is a barrier ointment, not a lotion, that can be found typically in the baby aisle to help prevent diaper rash. And this helps maintain the moisture of the vulvar area and prevents itching.
We love our A&D ointment, and you can actually keep that in your bathroom. And every time you use the bathroom and you wipe or clean up, put a little layer of A&D ointment on, and it acts as a great water barrier. One of the group of patients I always recommend A and D in are my incontinence patients, because we take care of a lot of patients who leak urine, and they always ask me, is my urinary pad causing my vulvar itching or my irritation? And the answer is maybe. It depends on the type. So certainly I want to make sure that they're using incontinence pads that don't have any fragrances or irritants on it. Unfortunately, when you see something on the package that says gynecologist approved or clinically proven, all that means is that they either got one gynecologist to try it and say, hey, this pad works, or they did a test where a patient said, oh, I like using these pads. That's clinically proven. So those terms on a package don't tell you much about the product inside. As long as you're using a quality incontinence pad, it should be pulling the urine away from the vulva. So that's fine. But if your pad is always wet against the vulva, that can have the opposite effect. It can actually break the skin down. So you need to change your pad as much as necessary to keep it dry against the vulva.
And there are some pads also that absorb the natural moisture of the vulva, which can cause you to have more dryness and irritation. So that's where the A and B ointment comes into play, which prevents that moisture leaving the vulvar area.
Exactly. In fact, for a lot of my patients, if they go through a treatment and they end up improving their incontinence and they're no longer leaking, it's kind of psychologically hard for them to break the habit of wearing a pad, even if they don't need it anymore. And really, we should be letting our vulva have airflow as much as possible. So if you don't need pads, we shouldn't be overprotecting ourselves because we want the vulva to have normal airflow to stay healthy.
As one of my favorite advice I give patients is to sleep with something loose at nighttime so that they're not suffocating the vulvar and vaginal area, and let everything breathe. And 9 times out of 10, they're like, what do you mean I cannot sleep with underwear on?
Exactly. Yeah. Sleeping without underwear is a great option for women if you're able to. Obviously, if you're suffering from incontinence at night, that may not be an option for all patients, but for healthy patients without urine leaking, it's a great option.
Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.